Hello, everyone. Thank you so much for being here. We are so excited today to talk about a very important topic about difficult dialogues. So let's get into it. Today, we are going to be talking about what difficult dialogues are and what they really mean in pain management. So, I am Michelle Maricos. Thank you so much for being here again. Um, I am a peer support specialist, person living with chronic pain. I am the founder of Moving Through Chronic Pain. And we are so excited today to have Dr. Sing Ping Chow with us. He is a PharmD from Florida that works inside of the Veterans Administration. So I'm going to let him introduce himself in just a few minutes. Today's topic is very important, and we just want to do some housekeeping things. So we are going to have some question and answer sessions at the end, but we are looking forward to your questions and your comments. So if you have questions and comments, please drop them into the comments section, and we will get to those at the end. And then, as a disclaimer, that this topic is very, very important to both providers that work with patients with chronic pain and deal with chronic pain themselves. But we also just want to say that this is, information. We're not giving out medical advice. This is about communication and about how to have communication effectively for both patients and providers. So, as we get underway, I would love Sing Ping to introduce himself and tell us more about himself. Sing?
Thank you so much, Michelle. It's so nice to be here and just have a conversation with you and have a conversation about difficult conversations. So, just a disclaimer for the content for today, it only represents my opinion and it does not represent my employer. So, with that, my name is Sing Ping. I am an inpatient pain management pharmacist. My role in pain management as a pharmacist, I would say it's very frontline because I do talk to patient every day. I gather their pain history. Then I would talk to them. I actually sit down with them and have a very deep conversation about what is going on. And then we will come up with a plan so then it's agreeable with the patient. They know what to expect. After that, then I would go to the doctor and then come and then discuss the plan, whether or not it's viable. And then I would execute the plan and then continue to monitor. So my role as a pain management pharmacist is very, very hands-on. So I absolutely love my job because as you know, in this day and age, being a pharmacist and having that privilege to be that having that kind of involvement and be the very, very front line in pain management, I think it's really important and it's such a privilege. And I'm so glad to be talking about pain on the difficult conversation today because this really is what I do day to day. The having difficult conversation is very bittersweet because it's definitely very sometimes it's a very emotionally challenging and very emotionally charged conversation, but in the end, once you get through that barrier, then it really opens a lot of doors and opportunities for not just for me, but also for the patient to have a better understanding about what we can explore together. So this is a very important topic that, I'm still learning. Everyone is probably still learning. And so, yeah, thank you so much.
Thank you so much for that introduction and a little bit of a deep dive into our topic today. So yeah, the definition of a difficult conversation. Let's kind of dive into that for a few minutes. I think because I'm so passionate about this subject, because I've been on the other side of so many difficult conversations, that's where this all stemmed from of like
Mhm.
communication is so very important, and that these conversations, whether you know you're going to have the conversation with a patient that's living with chronic pain or whether the conversation kind of pops up during an appointment, I think that piece of really being prepared for the conversations and what can go sideways very quickly, and why these conversations are can be so spacey in so many realms, because they are very emotionally charged. These are our lives. People
Mhm.
living with chronic pain are, very affected by their pain, and they are very emotionally charged um, topics. And so, a lot of the things around, our fears and fear of talking about our pain with our providers, and fear from the other side, from the providers as well, about talking about difficult subjects with their patients. And so it's that parallel process, two sides of the same coin, that as the providers having anxiety, the patients also having anxiety and a lot of emotions. And have you seen that in some of the difficult dialogues that you've had?
Absolutely. And I would say if it's not day to day, it could be multiple times a day. Because one of the things that I think it's sometimes it's overlooked is that when it comes to pain management, it's not just about, oh, I give you a pill and that's it. A lot of times, really, the first thing to even get the ideas across, like it doesn't matter if you have the most brilliant idea, but if you cannot get to the very core, if you cannot even get to the patient, to their emotional level, and have their guard down, they are open to your suggestions, meaning that they feel like they're being heard, they feel like they're being listened to, that they feel like I am talking to a person who is there to work with me. Until we get to that point, then I am not ready to talk about any of the recommendations because I personally have made that mistake. And I've also seen that mistakes happen, and which is fine, right? But we have to be cognizant and be aware that why is this happening? It's because, like you say, especially Michelle, that you have been on the other side, and so you can speak for it. That if you are not being heard, then it doesn't matter what recommendation you're about to give me because it's just not going to get across. It would just feel like a cookbook recipe. And patient is very patient specific, and they first need to be heard before I can even present what I'm about to say. So yes, multiple times a day, if anything, and it's a very real thing.
I love that you said the fear about not being heard, because I feel like in our patient population, of myself included in this community of people living with chronic pain, that is our number one complaint in these conversations, that we are not being heard and we're not being believed. And if if we can work on those pieces and change
Mhm.
those pieces, everything will change.
Yeah. And part of that is also, just to add on, why this could potentially be happening is because when, during, at least I can speak for, part of my training is that we focus so much on the technical skill. But what we're actually dealing with is a soft skill. And that is something that is not necessarily focused on a lot during the training. It is being mentioned. There might be, one or two lectures about it, but, soft skill isn't something that can be just like taught over one or two lectures. You have to practice it. You have to, almost like you have to make mistakes, embrace it, get better, ask for feedback, and be open to
Yes,
learn about it. But this is a skill that can be learned. Like it's not something that it can never be overcome because I have been on the other side where I was shy. I was not able to, face that conversation head on. So I was in that position too. So it's something that we can all overcome and get better.
absolutely, absolutely. And that's what we're going to dive into. So
Hmm.
some of these topics, that we are going to touch on today, a lot of pain management has to do with medication concerns.
Hmm.
And for the provider being uncomfortable, for the patient being uncomfortable with their medication and the topics around medication, and how those conversations go sideways very quickly.
Yeah.
And how do we have those conversations? How do we dive into those conversations? And how do we become more comfortable with that topic when the conversation does go sideways? And how do we, make ourselves as providers comfortable and
Mhm.
patients comfortable with that topic? And, really about requests for higher doses, tapering, safety risks. A lot of those conversations are so hard to begin with. And why do you think that is?
Part of that, I would say, especially when it comes to opioid, like opioid in pain management, it still has a major role, and it is still being used a lot in this country, and not so much in the rest of the world, but in at least in America, it is used quite a lot. But we know that with opioid itself, it's a highly stigmatized medication. I sometimes would go into the room and I would start talking to the patient. I would tell them that, hey, I want to talk to you about this medication called opioid. And I know, like, I would prime the discussion with them before they even react. I would say, I already know, I understand that this is a very sensitive, highly stigmatized opioid. Can we talk more about that? Because truth be told is that we all have some sort of understanding when we hear things from the news, when we read things online. Everything about opioid, there is often a lot of negative impression, negative connotation about that. So our this is a medication that is highly stigmatized. So that's why when it comes to just anything opioid related, then it can easily become a very sensitive topic, because what really associated with opioid, not just pain, there is also the other side of the spectrum, which is the opioid use disorder or the addiction, and that itself is also a very, very touchy and sensitive topic that nobody wants to really be perceived to be an addict. Nobody wants to be really perceived as weak. And so when we start talking about medication, all those emotion would just unravel. So that's why there's almost like not surprising why talk about pain medication. Being a pain management pharmacist, we are facing this difficult conversation head on every day, because everything revolving around this topic itself is very sensitive. It's just the nature of it. But the best we can do is to acknowledge it, and be the person to not judge them. And to not judge them, you have to first understand where the patient is coming from. Because I used to be like feeling like a little cringy, right? Everyone would start off, when we first learn this topic, when we first approach this subject matter, we will all feel like, oh, what am I going to do now? But then be the person to learn more about it, learn about what this is. And I would say, if you really want the patient to be in a better place, then try to understand what they are struggling through. Everyone's so different, everyone has a different goal. But just because I want them well, okay, but what does that mean? That itself has to come from the patient. That's why it falls back to the listening, the understanding, right? That communication, the empathy, all that is so critical and important.
And do you think that that basis for that understanding is asking those tough questions of what the patient has an understanding of around their medication?
So yes, and because part of that, I think you're bring up a very good point. Because first thing that sometimes I would ask the patient before I even talk about medication is what we call clarifying the expectation, right? Because what we thought as a clinician, we know, we're taught that medications can only do so much. But for someone who doesn't really have that medical training, who doesn't have that medical background, when they would be, patients would be thinking that, oh, medication is supposed to take the pain away. And that itself is a misalignment of expectation. And I would say it's really not on the patients, because patients are not, they're not signed up for medical training, right? I can't expect them to know that. So that's why it's very important for me to sometimes go back to the drawing board, so and ask the question of, so what are we looking for? What are we trying to achieve with this medication? So that, you brought up a very good point, is what we call it, clarifying expectation. We need to be on the same page in order for us to move forward, because if we're not on the same page, we're just going to be running into this very difficult conversation, because we would feel that the patient would feel like we're not understanding them, and we would feel like the patient is expecting too much. But what if the problem is we haven't clarified the expectation? We're not on the same page. Well, that might be the issue. Then we have to go back and talk about what is the expectation.
I love that. I think that expectations are so missed in so many
Hmm.
conversations. And I know for myself, going into provider appointments and having high expectations, I have the high expectations of, I want my pain gone
Hmm.
now. And
Yeah.
so it is bringing those realistic expectations, having, just as having really important conversations around medications. I think that the conversations around expectations are just as important, because it gives the person living the experience a framework of where can I live? Where do I need to live in my experience? And what is reality and what is not? Especially around, again, going back to the medications, what can the medications do, what they cannot do, and where that also lives as well. But I love that you brought up the expectations, because that is so widely missed. And I know that those conversations, you know, are hard, because a provider obviously wants to, have their patient do as well as they can. And when expectations need to be changed and lowered, it's difficult for both parties.
Yeah, yeah, and the you brought up like what it can do and what it cannot do, and something just from like a clinician standpoint is that part of the discussion that is often missed is also the potential side effects and the harm of that, and that is something that is where part of the difficult conversation will come from as well, because from a clinician we know that there are certain limit, there's certain amount of medication or dose I can go up before we're risking for side effects. And sometimes I would be very upfront and honest with patient, and honesty, by the way, is very key. But I would be very honest with patients that I really want to treat your pain, but I don't want to risk a side effect during in this whole process, when we are potentially pushing the limit too far. Because unfortunately, which is any kind of medication, right? Any medication is a chemical that has both the benefit, and also on the same other side of the token is what we call side effects. And those have to be very finely balanced, and it's not just about always pursuing the benefit. We also have to really make sure that we're aiming for safety, because safety comes first. As we practice medicine or pharmacy, the first thing that we even on the oath is like, we do no harm. How do we do no harm? We have to first recognize what is the boundary of the medication in terms of the side effects. So yes, not there's so many not necessarily
Yeah.
constraints, but there's so many aspects we have to really consider, in when we pursue medication management.
Absolutely. And I think that that goes for opioid medication and non-opioid medication, and the same,
Hmm.
expectations for non-opioid medication as well.
Yeah,
that, that goes along with the same, what are our expectations, what this medication cannot do or can do, and that, really background and setting the stage for that.
absolutely.
And then what about when we have these conversations and we have a trust breakdown? Like where do you think trust comes into these conversations?
Wow, this is such a this is such a good question, and
Yeah.
the trust breakdown, or I guess where the trust might kind of fall apart. I think part of that is can be attributed to is that all these time with the how the guide with the guidelines and with how we practice pain medication management, we follow a certain set of guidelines, right? But over the years things are changing. Like things are, when we look at 20, things from 20 years ago, we only have so much research, we only have so much evidence to support. Perhaps at that time it was a lot of focus on using opioid, and then 10 fast forward 15 years, then there is guidelines saying that, because with more research, then we saw that, okay, well, we see more harm and side effects from opioid. Then there is this whole, what we call the opioid pendulum, right? Swinging from one side to the other side. And then the other side of that is also, the physicians might be following the guideline too hard, and not really tailoring the specific need for the patient. And so there's just a lot of change. The patient have to go through so much change, and sometimes that change might not be explained necessarily well with them, and there might be resentment built up. There's so many things that can happen, and so many stories I've heard that really trickle down to, why, before a patient even come to me, there might already be some, shaky trust there, because of how, unfortunately, with all the changes happen over time that lead up to what we are seeing nowadays. But in order to really, for me, right, because when I go to a patient, the first thing that I would really try to do is to establish the trust and rapport. I don't really, I acknowledge all these things that have happened in the past, 10, 20 years. So for me to really reestablish that trust and rapport, I almost have to tell them that we start from scratch. We start from scratch. I will do my very best, and that's why, for me, like, I would be my very best and give them the time to express themselves, make them feel, and make sure that they feel heard. Again, a lot of that is really communication. A lot, and because that's where the communication builds trust and rapport. If we do not set aside the time to have that conversation, let them talk about their past and let them talk about the history, we will not be able to break that cycle of that mistrust, or lack of confidence in healthcare. So we have to start somewhere. And where does it start? We got to start with, give them the very best, do things the right way, give them the time they need to be heard and have time to talk about the story.
Absolutely, absolutely, and I think that that is a perfect segue into what we have as an offering for today. Difficult Dialogues, a patient-provider conversational scripts. So, we are offering Difficult Dialogues. Um, these are scripts for providers to use with patients. Sing Ping and myself have put together series one, and series one is specifically around diagnosis, medication, and treatment of chronic pain. So there is 10 scripts inside series one, and we are going to be talking more about something very exciting that we're going to be doing in June. So we're going to talk about that in a little bit, but I wanted to kind of bring this up about difficult dialogues. And, these scripts are meant exactly for all of these topics of open dialogues, difficult conversations, that so many times of talking to providers, it is, what do I say and how do I say it? And this is, really that foundation of building trust, bringing in um, empathy, compassion, really using a lot of guidance around languaging, what languaging helps, how, we can use alternative languages to help in these conversations, really the practical strips around these topics and emotional centered questions for providers to be asking and to be answering in these conversations. So I think that is a really nice segue into, our offering for today of difficult dialogues. And thank you so much, Sing, for helping contribute to those. Sing really put in a lot of time and effort into, all of these scripts and the manuals. We have a user guide and a series 1 guide, and then the 10 scripts. So we're just really excited to have you, contributing to that, and, being able to offer a conversation, and communication lessons to providers, and, to really be able to help move our population into a different space with living with chronic pain.
Absolutely, absolutely. Because, like I say, this is almost like a topic that is rarely talked about or rarely taught, in any kind of medical training. And this is something. And as a matter of fact, we need to have that skill in order to, as we talked about earlier, to really break that mistrust or really continue to build trust for the patient. If we do not have that skill set or we do not have the tools, it's very difficult and challenging to get to where we need to be and move forward to have better pain management.
Yeah. And really, balancing the needs of the provider and the patient, that we both have similar needs. We have a need to move our relationship and move our relationship with our pain into a different, realm, that we always want to be moving forward.
hmm Yes, and moving forward and really have a plan, and also have a plan for that's working forward, and also a backup plan in case things don't work out the way it should. And that's why pain management isn't just about medication. It's really the more I practice pain management, and specifically in medication management, I realized that it's not just about a pill or like one or two medication. It takes a village. It takes not
Yeah.
just medication, but also the spiritual support, the mental health support, the coping skills. And on the patient's end, they have to really continue to invest in you know being better, because those are all the things in order for pain management to work. It's not a one-way street. This is a collaboration. Pain management is, the more I learn about it, the more I practice, the more I feel like this is a two-way street, not just a one-way.
Yes. Yeah. And how do you kind of, when you have patient resistance, like I've been a resistant patient before, I'm sure in many of these conversations,
hmm
what what helps with patient resistance? What are the strategies that you use with patient resistance when it's that thing of, no, that doesn't work. No, I don't want to do that.
Yeah, yeah, yeah. That is such a good point that you brought up. I came across a book called Never Split the Difference, and it is such a good book about communication. And something that when sometimes when patients approach me saying that, things don't work, or, like you mentioned, something that I would do is I would name the emotion, because when the patient tell me that things don't work, usually there is some very intense emotion associated with something that they would feel like things either work or don't work. And when I sense that apprehension, that, when I present a, suggestion or recommendation, and I see hesitancy, then instead of brushing it off, I would call it out. I would name the emotion. I would say, I sense some apprehension. Keep it at that. Like, I sense some, I sense some hesitation, and then give it a little pause and let the patient elaborate as to what is their experience really before. And that naming the emotion, by recognizing the emotion at the time when they respond to a certain recommendation, yay or nay, that by acknowledging that emotion is so powerful. And I've been using the technique for some time now, and it's really helpful, because it opens up, instead of saying that, dismissing that recommendation. It could be a recommendation that they have not even tried before, but when I say, okay, well, I sense some apprehension, then they would share with me stories that I've heard from friends, or I've seen things online that they cause a lot of
Mhm.
harm. Okay, well, great. Then let's explore that, because that is really where my job really is to give you that the information, in terms of counseling. But if we do not address and not recognize that emotion, then we will not be able to open up that dialogue. So recognizing and name the emotion. Just say, I sense apprehension. I sense some hesitancy. And then leave that conversation open. A lot of times patient would, start sharing why they are feeling a certain way.
Absolutely. And I think that opening the door for that, as a person living this experience, it gives me the place of that I can talk about my fear. I can
Mhm.
talk about my anger. I can talk
Yes.
about, my mistrust of the system. I can
Hmm.
talk about, all of the things that are happening. And of course, you do open the door, and, us as patients, we do kind of dive down the rabbit hole of all of our emotions. But in a lot of senses, that gives you more information of where I'm coming from, of why I have resistance in the conversation of any kind of change, or any kind of, what the expectations are. And is that resistance based in fear? Is it
Hmm.
based in anger? Where is it based in? And I love that, softly addressing it in a way of like, I'm sensing this emotion. It
Hmm.
takes the onus off of the patient, and
Hmm.
it, gives you ownership of, like, I'm feeling something. How does this feel to you? Giving
Yeah.
that offering.
Yeah, and even if that emotion is, what something that they're not necessarily feeling at the time, like if I sense apprehension, but what they're really feeling is, another emotion, they would correct me, and then you just go, okay, well, I apologize, but let's hear that. Let's hear that. And but by recognizing that there is a very, there is some emotion building up, and open that door to explore the emotion, that is so powerful, because when it comes to pain management, it's not it's there is a lot about physical, absolutely.
Absolutely.
There's also a lot about emotional, and that part itself is, unless you have, unless you identify that, unless you let the patient allow the patient to let it out, then again, going back to the drawing board, until the emotion state is being addressed, we will not be able to get across our recommendation. Doesn't matter how brilliant that idea is. So naming the emotion, I find it so beneficial.
So absolutely beneficial, and the basis of building trust, of
Hmm.
that, if you're identifying that I'm having difficult emotions around a difficult conversation, and I do start opening up, that gives you so much insight into my experience, whether you've worked with me for many years or you're just seeing me as a new patient living with chronic pain, that it gives you more insight to my experience and how I'm basing and thinking and feeling around my pain. And
Hmm.
so much of our pain, yes, it is physical, but so much of it is our thinking around our pain and our feeling around our pain. And that those pieces get missed so often in these conversations, and really can hook us. And I'm feeling something and I haven't gotten to say something about what I'm feeling.
Yeah, absolutely.
Yeah, that is amazing. That is really amazing. Now I want to talk about, the active listening for a minute.
Okay.
That because we've talked about the active listening, what parts of active listening has a patient and a provider done wrong? So, like in my experience of working with patients and myself,
Hmm.
that I think I get caught in the piece of, if I'm confused in the conversation about medication or pain management in general, that I have kind of gone offline, sort of
Hmm.
in a way of
Hmm.
that I stopped listening because I got confused somewhere along the way because of the nomenclature or
Mm.
because of my feelings coming up. And how can we, when you notice a patient kind of going offline of like, oh, this conversation, they've stopped active listening, how can I steer them in the right direction back into the
The right
conversation?
course. Yes, yes,
Yes.
that happens because that is such a good point, because like we talk about how with physicians and clinician pharmacists, we learn a certain lingo, and then sometimes we even forget. And I would give you a very good example is that when it comes to a lot of medications, when we give it what we call as needed, so when you need it you take it, we will use a jargon
Mhm.
called PRN. And sometimes we would just accidentally go, oh, you take this medication PRN, and then you will sense a little it's a very subtle. They go this. And then so part of the active listening is to pay attention to the body language. Just when you are in the room, sense whether or not they are comfortable, sense whether or not they are giving you some verbal cues of misunderstanding or confusion, because over time as we interact more and more patients, then you can sense a little bit of frowning, or they can give you a blank look, and they would look like they're distracted. Catch those emotions, catch those moments, and just call it again, call that out, and say, I seem to sense some confusion here. Or I would even say, how are we feeling with our discussion so far? And when it
Mhm.
comes to active
Mhm.
listening, one of the technique that I learn also is to do a short summary. So, meaning that when I am sitting in front of a patient, I'm not just letting them talk. I'm also, taking notes. I'm really listening. I'm learning about their history. If there was something I'm confused, I would ask them questions too. That way they feel respected. They feel that someone is actually taking notes and listening. And by the time they're done, I would say, okay, so here's what I think I understand so far. And I would give them a 3, 4 line of a summary of what I've learned so far. So when I do my interview with my patients, it's very structured, even though sometimes I would play it by ear, but I would be, when it comes to evaluating the pain history, when the patient is done, before I even move forward and talk about medications and recommendation, I would do a recap. Having a recap and summary of what they talk about is, again, very powerful, because that really signals to the patient that you are listening to them. And also, if there's anything that is, that the patients feel like I misunderstood, or I got it wrong, allow that opportunity for the patients to correct me. This is a two-way street, right? Because and I like to tell patients, for me, in order for me to help you the best, I need to understand you the best I can. So feel free to correct me if at any time point I got something wrong, or you feel like something that you are unsure of. So that really is the essence of active listening. Pay attention to their body language. After some important points that patient um, tell me about, then do a very short summary of what that is, so then we are always going to be on the same page before we move on. So that itself is, that piece of active listening skill is something that I find very valuable, and I'm continue to practice every day and get better and get better.
I love taking the pauses. I love reiterating, back to the patient. I love, you know, that scenario of, really setting yourself up to be successful at active
Hmm.
listening. And I think a really important part of active listening is, along with active listening, is validation.
Yes.
Validating the experience that, the person is going through, of I understand, I hear you, this is their experience. And, you know, kind of that partnership of active listening and validation, and how, those two things go together. So, like peanut butter and jelly.
Yeah, yeah, absolutely. And I like to also tell patients that because like you said, validating is so important. Like pain is indeed a very unique experience. I the way that and I tell patients, your 5 out of 10 pain or your sharp burning pain might be a complete different sensation or a complete different degree to what I would have experienced. So that itself, by providing that validation for acknowledge that every patient's pain experience is so unique to them, is so valuable, and patients do need to hear that. That really helps bridge the gap and really build the trust to get to a better place.
And building the trust of that foundational relationship with your provider. Patients want to have a great relationship with their provider. They want to trust their providers. Absolutely, because, really, we've looked at you for our lifeline. You're our
Yeah,
lifeline in this journey. And if we can't, trust you and understand where you're coming from too, that lifeline gets broken.
absolutely. Yeah, and then if that, especially when it comes to pain management, I think pain management is, of course, I might be biased, but pain management is such a different field, just like mental health. It's a field where it takes trust. Like this is one of the field that takes trust in order for things to work. If there's no trust, then there will be no communication. Then there will be it will be very difficult for the patient to be open, to be honest, because those are the things that as a physician I need to have. I need to have an honest discussion. I need to have honesty. I need to have openness in order for me to make my best judgment. If we don't have any of that, then we just can't. It's so difficult. So again, pain management, mental health, this is one of those fields that is so different, that we need to actually have the trust. We need to have that collaboration in order for any of the things to work.
Yes. Collaboration, I believe, is again one of those foundational components as well, of like, it is not just, the patient or the provider. It is this relationship, the collaboration of, working together to
Mhm.
get, treatment and management in place that will further the person living their experience.
Absolutely.
Yeah. So we are about at the end of our time for discussion, but I want to we're going to do a little bit of Q&A, and then
Mhm.
we're going to talk about some of the comments. We've had such a great comment section, so I'm going to bring up some of those comments in a second. But I want to bring up our offering around our Open Dialogues workshop. Sing and I are going to come together and do a real workshop around dialogues, difficult dialogues, around all of these things. We are going to do a role play. We're going to do some didactic pieces. We are going to go over our scripts and go through, diagnosis, medication management, relationship building, all of the foundational components in series 1 of Difficult Dialogues. So this will be happening Saturday, June 7th. And so we invite you all to sign up for our workshop. We are very excited to do this workshop, and we're going to be doing more workshops as time goes on, but this is our first one, and I'm just really excited to work more with Sing Ping. And we've had such a great discussion today that we are going to continue the conversation and do actually deep dives into how all of this actually looks in a clinical setting. So we're really excited to offer this, and we invite all of you to sign up and ask questions and bring in some difficult dialogue examples. We will have lots of examples to go over, but participants are welcome to bring in examples of how conversations went wonky and what they did, and all of the examples. We want, this to be a really enriched conversation with Sing and myself and all of you. So we're looking forward to that on Saturday, June 7th.
Very
So
good.
let's go into some of these comments. We've had such a great comment section. I'm going to bring up this comment. That we really want to talk about how pain is not imaginary, that it is the concept that people living it with pain really hate hearing about pain is all in your head, and how that conversation will instantly go bad, because we do not want to hear that it is definitely not imaginary. It is not all in our heads. Pain does come from the brain, but that does not mean that it is all in our head. So when you hear a patient kind of going down the rabbit hole of like, don't tell me that, what is your response?
So I would acknowledge with the patient that this is definitely not pain is not in your head, because as we know that pain is, I would say, instead of thinking that pain is in your head, pain is unique to your experience, right? And so my job is to help you navigate this experience through medications, but also with other things. And so by reframing, by restructuring that mindset, that we're not saying, we're not denying, we're not here to deny and say that because when we say that pain is imaginary, we're basically dismissing the validity of their pain, right? So some of the things we know that there's physical pain, there's also the emotional and the mental pain, and those two are very real. And so yes, there are medications for it, and we also want to provide you other support to really help you to navigate this. So by acknowledging once patients become they would become agitated when we say that the pain is in their head, the first thing, again, acknowledge the concern, name the emotion, allow them to express why they feel frustrated, right? Because if the patient already come to me saying that someone told me that my pain is in my head, then I know that all the trust is already gone. Then we are almost like have to start back from scratch to rebuild that trust. going back to active listening, acknowledging emotions, and then allowing patients to express their emotions, then we go forward. So, yeah, unfortunately, that might still happen. I don't think that it's really happening, in my practice that much anymore because, now that we've provided more training to a
Yeah.
lot of clinicians, but I do know that it can still happen, unfortunately. So keep an open mind, acknowledge that it's not, pain is not in your head. It's a very unique experience from patients to patients.
Absolutely. And I think we've come a long way in those conversations with those stigmatizing phrases, but we have a long ways to go. We're always learning. We're always, we always want to be growing and learning in these conversations, and as providers and for patients as well, becoming more comfortable with talking about these really difficult subjects and these difficult dialogues, and having a way to be able to express those emotions, express the thoughts, and express the stigmatizing language that we have used in the past,
Yeah,
that there has been a lot of stigma.
yeah, and like something that you and I have talked about before, be comfortable being uncomfortable. That itself has really helped me be a better communicator when it comes to pain management because a lot of these things at the very first it can be uncomfortable. I'm not saying that it's easy. None of these is easy, but by being having an open mind to be a learner, having an open mind to the idea that this is going to be uncomfortable, but as a clinician we have all the power, we have all the knowledge and the resilience to become comfortable with uncomfortable. I think that is a mindset that we just have to kind of move towards that in order for us to become a better communicator in pain management.
Yes, absolutely. And I love that. And I think that's a good segue into my last question for you. What are the things that you do to prep yourself before you go in and have those difficult conversations? If you know that you're going to have a difficult conversation with a patient, and what are the things that you're doing before you step into the room?
Yeah. One of the biggest thing I would say, biggest thing is do the homework. Do the homework, read the chart. I cannot emphasize enough that before I would go into any patient's room, the first thing that I would do is read through the chart, understand where the patient was, where the patient were, how do they get to the point where they are today in the hospital that they are seeing me? Because if I have had so many times, and it is also mentioned in a guideline where patients actually feel that they're not being heard, or they feel that the doctors and clinicians are not spending enough time to read the chart and do the homework. So the first thing before I even go in there is gather as much history available on the chart. People do, they spend time writing chart for a reason. They want you to they're communicating their thoughts. They are leaving breadcrumbs throughout the chart for me to follow, to see where they were to where they are. If I do not do that part, if I do not even prepare myself for and have a very basic understanding of what they have tried or what they have done in the past and where how they get to where they are today, then I fail them because it is on me to do the very bare minimum, which is to review the chart thoroughly before I go in there. So then when I first even start the discussion, I already know some of the very basic, information about the very person in front of me instead of starting from scratch. I'm not talking to a stranger. I'm talking to someone that I have some idea already because I have read through a chart. And when you actually, something that I also find very beneficial is that patients can tell whether or not you have done your homework. Like
Mhm. Very
if
much
you
so.
yeah, if you haven't done your homework, patients sometimes would call you out. But when I have done my homework, patients would actually express the gratitude that oh, you actually read my chart, and I go, yes, I did, because that's part of the workup. That's part of the, before I even prepare myself for the difficult conversation, then I would see what is it, so then when I, even before I go in, I already know I'm not going to present something that you have tried, that you're allergic to, that you have a bad reaction to. Because if I do that, then you know right away I didn't do the homework. Again, no trust. Because for any patients to feel that you have invested time for their care, they need to first sense that you have done your homework. So number one thing, before anything, do the homework. So important.
Yeah, you bring up some really good points that make me chuckle. Of I'm thinking about all the times I've gone into provider appointments where I felt instantly dismissed because they didn't know why I was there or what my experience was or any of it, and you feel instantly dismissed, and how
Hmm.
horrific that feeling is, starting a conversation off or an appointment off of, well, okay. It's just, yeah, I 100% agree, and I really love that you said that. That means a lot, and I think it means a lot to patients that a little preparation goes a long way.
Absolutely. 100% to that.
Yeah. Yeah. Well, thank you, Sing Ping, so much for being here with me today. I loved this conversation. I love this discussion. I'm really looking forward to our workshop. I'm looking forward to deep diving into, scripting, how to do the scripting, examples, role playing with you, showing how anger comes up, emotion comes up in our real, scenarios. And so we are going to do that June 7th in our workshop. And I'm so thankful for you. And you just do great work. And I am so thankful for everyone being in this conversation and all of your wonderful comments. Continue commenting, asking questions. Please reach out to Sing or I. We would love to talk about any of these difficult conversations and difficult dialogues at any point in time. And yeah, we are going to sign off for today. Thank you so much for everyone that watched. And we will be back doing more LinkedIn Lives later on. So thank you again.
Thank you. Thank you so much.